Hi guys, welcome to lecture 2 in mobility. Sometimes my Zoom has a little bit of trouble because I'm not the most technologically proficient of all of your instructors, but we'll just keep working through this. I'm sure some of you can relate for me. Let's work on getting to the PowerPoint that I need to do. So we're going to work on mobility. We're moving into the fractures, traction, casting, and compartment syndrome period of this lecture. I'm going to share my screen with you, and we'll go into the PowerPoint. All right, slideshow from beginning. Okay, so we're going to talk about fractures, like I said. So a fracture is a disruption in cortical and cancellous bone. What that means is the bone is disrupted. Maybe just part of it, maybe the surface, maybe all the way through, and it causing a complete fracture. Sorry, I'm just putting my phone on silent so we don't get any phone calls during the lecture. What happens when the bone is disrupted, the muscle insertion points on either end, so they start to spasm. The muscles spasm. They've had a traumatic injury. And so what they'll do is now the bone isn't strong enough to support it in a solid area. So as the muscle spasm, it'll pull the bone out of alignment. The injury itself and the bone fragments can cause blood vessels to be disrupted. So you have capillary, venous, or arterial leakage, depending on how bad the injury was. Most of the time, it's capillaries and venules that are leaking. You get bruising and blood loss. It can be a lot, though, and we'll talk about that in a minute. So there's different kinds of fractures. There's an open fracture, which is significantly a big deal in nursing. And if you see this on boards, this is something you're really going to pay attention to. An open fracture is where the bone breaks and it completely protrudes to the surface of the skin. So the bone and the underlying tissues are exposed. That makes the patient really high risk for infection, and it causes that patient to have problems with potentially cellulitis, potentially sepsis if it gets really bad. Treatment for osteomyelitis is 8 weeks of antibiotics and complete rest of that bone. They can get IV antibiotics for a couple of weeks, and then we go home on oral. They can do home care IV antibiotics, but still it's a long treatment plan, and it takes a significant amount of work to get that better and to get your patient healed from that. A closed fracture is when the surface of the tissues are never exposed. So the bone fragments are broken, but they're underneath the surface of the skin. So there's less risk for infection. So then after that, we start talking about the shape and the direction of the fractures. So transverse fracture, if you look at the far right leg in the bottom photo on this slide, you can see in the middle there's a transverse fracture that goes completely across the bone horizontally. A linear fracture is represented the top part of that bone on the far right leg. And you can see it goes up and down vertically down the shaft of the bone, a linear fracture. And that is an incomplete fracture. We'll come back to that in a minute. And then the oblique fracture means a fracture on the diagonal. So the other types of fractures that we're going to talk about, there's a spiral fracture. A spiral fracture is caused by a rotational injury. So the body part is twisted. It could be from an industrial accident where you get your leg or your arm cut in a fan or an agar, and it rotates it, that causes that bone to break in a spiral. But the reason we always want to check the mechanism of injury against the type of fracture is because a spiral fracture is often seen in a child abuse or domestic abuse case where somebody has grabbed the arm or the leg and wrenched it and twisted it, and then it caused a breaking of that bone. So when somebody comes in and we identify a spiral fracture on an x-ray, always verify the cause of the injury, because if they said they tripped down the stairs, it's not going to cause that kind of injury, and it bears a second look. A comminuted fracture is represented on the farthest right bone on the picture at the bottom of this slide. And you can see it's got little fragments. The bone has shattered, and there's lots of little fragments in the bone that need to be healed. An avulsion fracture is represented on the x-ray at the top of this slide with a blue arrow pointing to it. An avulsion is where a chip breaks off a bone, and instead of the bone length of the bone, being disrupted, there's a chip out of it. So you can see the blue arrows pointing to the little piece of the patella that's chipped off. And that what has to happen is the patella has to heal. That chip may not completely re-adhere, but the patella has to regrow there. A displaced or a non-displaced fracture. A displaced fracture is when the muscle spasms or the mechanism of injury is significant enough that the bone is no longer in alignment. If the bone is in alignment, it's a non-displaced fracture. If the bone is not in alignment, it's a displaced fracture. There's also a green stick fracture. A green stick fracture, I want you to think about it like if you had a pencil and you started to snap the pencil. As you started to bend it, the little wood fragments would break off and start to stick up like this. Well, the same thing happens on a bone. Is a bone is bent, the fragments turn up and you get these little fragments on the S side of the bone. You can see it's not in the farthest right, it's in the second to the right bone on the bottom of the slide. And you can see where the bone has been bent and the fragments start to stick up. An impacted fracture is not represented on this slide because it's really difficult to see that that's different from another fracture, but it's a mechanism of injury that's different. If you were running head on and you ran with your arm out in front of you and ran straight into a wall, or something significantly heavy pushed against the length of your bone and it pushed that bone in and on itself and broke it, that would be an impacted fracture. A depressed fracture is generally in the skull. That's where we usually talk about depression fractures. And that's because something has hit you in the skull hard enough to cause the skull bones to indent down into the meninges or even into the cerebral tissue. And that would cause a depressed fracture, and you'd have a skull fracture from that. We'll be talking more about those when we do intracranial regulation later in the semester when we talk about head injuries. And a spinal compression fracture is what we often see in the elderly patients who have bad osteoporosis. As the spine demineralizes and decalcifies, the bone becomes brittle and fragile. And so the weight of the body, remember one of the things we talked about in the last slide is as we age, the discs become compressed, we lose the fluid in the spinal column, and now the bones are demineralizing, and yet the weight of the patient is still walking around vertically, and your spinal column is bearing a portion of that total body weight. And so what happens is it compresses those bones and it causes a compression fractures in the spine. That's largely what's responsible for that Dowager's hump that some of our older women get as their osteoporosis worsens. They get that little hump in their thoracic region. There's certain compression fractures, and then the bones are pulled out of alignment. So the symptoms of fracture, you need to be aware if somebody's fallen, has an injury, what are we looking for to determine if this is truly a significant injury? It is very difficult to tell the difference between a sprain, a strain, or a fracture. You truly need an x-ray to do it. But let's look at the initial symptoms. Some things are obviously a fracture, a deformity of that bone, where the leg or the arm or whatever body part is laying in an abnormal direction that is not physiologically possible without a bone being broken, and that's a pretty good sign your bone is broken. Or if you have an open fracture with bone sticking out, also a pretty good sign. But so deformity would be our first one. Swelling and edema, we're going to talk a lot of the process of what happens is the process of inflammation. Inflammation is intended to clot and heal. And so the initial mechanism that your body is going to fight with is inflammation. And so swelling and edema is one of the cardinal signs of that. There's going to be capillary leakage, and you can have fluid leave, and you have white cells leave. And some of the chemicals that are secreted from the tissues that are damaged are going to cause a further leakage in the capillary beds, causing more edema at the site. You're probably going to have bruising because the blood vessels have been disrupted, and so capillaries, venules, veins are leaking into the tissues. We're going to have a loss of function, especially if it's a complete fracture, where the bone can no longer support the weight or do the job it's supposed to do. An incomplete fracture, sometimes the patient will still have function in the arm or the leg or whatever. Think stress fracture in an athlete, where they were running and the force of the running and the repetitive mechanism has caused them to have small linear or partial incomplete fractures in their ankle or their bone and their foot. And they still have function in that foot, and it's painful and it's swollen, but they still have function. That's probably from incomplete fractures. If you have loss of function, you probably have a complete fracture. Another thing you might experience is pain and tenderness at the site. Again, process of inflammation. We're going to be releasing prostaglandins. We're going to be damaging, the patient is going to have damaged their nerves because of the injury itself. The edema is putting pressure on the nerves, the loss of blood supply or diminished blood supply, depending on the type of fracture, or damage to the nerve itself if it's a massive traumatic event. So we might have pain associated with that. Crepitus is the popping, cracking sounds that can happen at the joint from bone rubbing bone. It can also be from air in tissues that you hear a snap, crackle, pop. We're going to talk about crepitus in several places in the program. You'll hear it again in level 4 when we talk about pneumothorax and chest tubes. But think of crepitus as Rice Krispie treats snapping and popping, Rice Krispies snapping and popping in the tissues. The other thing we're going to talk about is neuromuscular symptoms. And with neuromuscular symptoms, the injury is going to happen to the blood vessels and to the bone. But again, the swelling might cause the nerves to be damaged, the nerves to have a decreased perfusion, the nerves to have excessive pain, especially if we have enough swelling that it starts compressing the nerves. We're going to have neuromuscular symptoms. So we're going to talk more about those shortly because we're going to be doing neuromuscular checks, neurovascular and neuromuscular checks every couple hours. Then vasodilation, again, this is the process of inflammation, capillary leakage, and the body's basic premise is bring blood supply to the injured area. White cells, red cells, platelets, we need to clot, we need to treat infection. So the body's natural response is to bring blood flow to that site. So vasodilation will happen initially. Then again, loss of mobility, loss of function. I know you studied hip fracture last semester, and with a hip fracture, when the patient falls, the mechanism, if you think the ball of the femur at the top, it's a ball and socket joint. So you've got your hip socket and you've got your femoral ball up in there in the top of the femur. And if you've got a fracture anywhere here or in this hip socket, what will happen is that it will shift. It will become dislocated and out of alignment, and it will cause that leg to externally rotate and to shorten, as like if this hip part here breaks, the ball is not held in that socket anymore, and it shifts and the hip actually shortens and externally rotates. So if you come across somebody who's fallen and you see their leg is externally rotated and looks shorter than the other, then that's a probable sign of a hip fracture. So if you think that they're not going to be able to move that leg and have any function in it because the ball and the socket are no longer there. So the patient tried to get up, they're not going to be able to wait there on that or do anything else. Another thing that happens along with vasodilation and the edema is the exudate of white cells to the side, again, to combat potential infection. Our body doesn't know at first at the time of injury what the cause is, so it has a normal response until the body goes, oh, look, we're white cells and we don't see any bacteria to clean up, so that will go away. But what you see then is heat, pain, redness, and swelling at the joint, which is inflammation. It's meant to heal, meant to initially help, and so it's a good thing. After somebody has a broken bone, they will move into the stages of healing. And the body starts almost immediately. Initially, you'll form over the first 24 to 72 hours a hematoma at the site. You're going to build up a blood clot at the site where all the vascular stuff is going to stop leaking and you can have clotting occur. You began to study clotting last semester, and you know the mechanism, internal, external clotting cascades as they are triggered and they start building a hematoma. And that hematoma is going to stop the blood and give some substance in that site. Then the body is going to send in. Now remember, the body has sent in increased soldiers. It sent in more white cells. It sent in platelets. It's brought other cells from other parts of the body, and it starts to produce the things we need to produce to heal. You recognize bone has been disrupted, so the body produces more osteoblasts. The osteoblasts will proliferate, and they'll run to the site. So the white cells are going to clean up and gobble up and help to dissolve that hematoma. Uh, in our natural body processes, within 7 days, most blood clots are dissolved. 7 to 14 days, most blood clots are dissolved. So we form the hematoma, and then the process of inflammation and healing dissolve that hematoma. But during that time, the osteoblasts and the chondroblasts are coming in and they're doing their job. They're laying down a spongy matrix and they're forming what we call a soft callus around that side of the bone. It's going to give it some structure, some cellular structure. So as the patient's diet is good and they rest, then that bony matrix, that soft structure, can calcify and harden. But over the course of the next 2 to 6 weeks, this callus is going to form around the side of the break. And then over the next, the calcification starts even as early as 3 weeks. Some calcification will occur. That can take up to 6 months to completely occur. But if you see that bony matrix and that callus formation is complete at 6 weeks, that means there's some structural support around the bone at that point. When you think of anybody you know that's ever broken a bone, or if you've broken a bone, when they put you in a cast, the usual length of time a cast is on is 6 weeks. And that's because we know at about 6 weeks that callus will have formed, and they'll be doing x-rays to determine the appropriate time to take the cast off. But at about 6 weeks, we know that callus has formed and the process of calcification has begun and will continue. And at this point, if we start weight bearing or using that extremity more, that's just going to enhance calcification. So we take the cast off knowing there's some support and structure that's rejoined that bone. So then over the next 3 weeks to 6 months, calcification, the recalcification of that bone is going to occur. Now it's just going to be random. That entire soft callus will start to calcify. And so after a few months, 6 months, up to 6 months, after that, then remodeling will occur and osteoclasts will come back in. And that initial callus was kind of a bump and it may not have been the same exact shape and it was meant to support that broken area. But the osteoclasts will come back in over the next year or so and remodel that bone to make it smooth and look like it was intended to look like. So by definition, a patient who's had a fracture is a trauma patient. They have had a traumatic event. I know all of you have learned the ABCs, airway, breathing, circulation, old hat, right? Now with trauma, our ABCs go all the way to G. I'm going to take you to E today. If you were to get trauma nursing certified when you get out of school and you decide you want to work in an ER, I recommend you take the TNCC Trauma Nursing Certification course. And they will teach you A through G actually in the ABCs. And it's a consistent, reliable way of assessing and intervening and treating based on the priority setting for your traumatically injured patient. So it's airway, breathing, circulation. You have to get the airway fixed if they don't have one, assure they're breathing, assure they have basic perfusion. At the same time, we're also going to be looking for bleeding and hemorrhage. C also, the C, next C is C-spine, because with this patient being a traumatic patient, it could be that there was neck and head injury and we want to stabilize the C-spine. The next thing we're going to do is look for disability. And again, that's going to be where a fracture often shows up. Your patient's leg is at a weird place, the bone is sticking out, hand, leg, ankle, whatever. So we're looking for obvious signs of disability. And in order to do that, we have to expose the skin and we also assess the environment they're in. If you are in the ER, that environment is a safe and secure environment. We just make sure the call bells and the rails are up. But if the patient is out, they jumped out of their bedroom window because of a house fire and they broke their leg, or if they were in a car accident and there's gasoline on the ground, or if they were in an accident during a rainstorm and there's an electrical wire loose from a power line, the environment could be very dangerous. And so we want to secure the patient in a safe environment too. So, but we have to make sure they have an airway and they're breathing. So sometimes the environment moves up, but most of the time it's just, let's check this environmental world that they're in, make sure that their temperature, the external temperature is okay, that it's a safe environment, have everything in and on them. So the video is a trauma doctor's assessment of discussing the ABCDE of a trauma patient. It's not anything you're going to be tested on other than, I think you already know, airway, breathing, circulation. We are going to do C-spine in this unit because we're moving into spinal cord injuries later in this mobility unit. So that would be C1 and C2. Mobility is disability. So you can go through A, B, C, D in this unit, and we'll have got you all the way through the first 4 or 5 steps. But you don't have to memorize that video. I put it in there for you to watch if you're interested. It gives you a little bit of foretaste of some of the things we'll also be doing in level 4 because we're going to keep moving forward. I can't wait to get you this summer. All right, so the next thing we also want to make sure, the patient may complain of thirst. A lot of trauma patients say, can I have a sip of water? Can I have a drink of water? You have to remember their capillary beds are leaking, fluids are leaking into the tissue, and they may feel like they need to replace their fluids. We absolutely, all trauma patients are NPO until x-rays are done and we know exactly what's happening. There's a good chance patients will go into shock. If the patient has a hip fracture, that hip capsule can actually hold a liter of fluid. So you can have a liter of blood and fluid leaking into a hip capsule. So of course they're thirsty, but they could go into shock. And if we're giving them things to drink, we're stressing abdomen, we're possibly causing emesis, very likely, causing them to have nausea, vomiting. And then there's always the concern of, is paralytic ileus going to set up in these first 24 hours? So we place them NPO until we get a good solid assessment. If an ambulance is around, the patient's going to get an IV. If they come into the ER, you're going to get them an IV, but we're not going to let them take anything by mouth. Then we also want to find out what happened. Does the injury match the history? Is there abuse going on? Do we need to remove a potential abuser from the room? You know, we always ask the questions of a patient when they're alone. We talked about that back in interpersonal relationships, I believe. Are you safe? Has anybody hurt you? Okay, and then after we find out what happened to them, if it's an open injury, we want to get antibiotics started almost immediately. Chances are if you have an open fracture, it wasn't clean. It wasn't in a sterile environment. So they probably have gravel and dirt and grass and who knows what all else in that wound. But we're also going to immobilize that extremity. It is not the nurse's job to reduce the fracture or to cast it or anything else. The nurse's job is to immobilize it in the position it's in while we send them for x-rays to find out if it's truly broken, is it sprained, is it aligned, not aligned? You know, so do we have, what kind of fracture is it? What are we looking at? Before we start moving it around, we want to know what kind of injuries in there so we don't mess with things and cause the injury to become worse. Sometimes that involves MRIs and PET scans, but an x-ray, if we suspect bone fracture, is going to be our primary initial tool. And then after that, we're going to move into fixation and reduction. Now there's more on that on the next slide, but basically reducing is pulling the fracture into alignment and fixating it is the process of immobilizing it. So when we talk about these processes, this is the healthcare provider's role. Our role is to support them, make sure they have the essential tools they need. We're also going to support the patient, teach the patient as they're going through this process. And we'll be doing this, the nurse's role of education, support, teaching, and assistance. So there's 2 kinds of reduction. There's an open reduction and a closed reduction. In the picture at the bottom of the slide, you see a closed reduction in process. That's the alignment of the patient's bone. So in that picture, you've got a provider pulling the bone out and pushing the bone back into alignment. So they took an x-ray, they saw a displaced fracture and how it was displaced. So they manually manipulate the arm until they can get everything back in alignment. That is a closed reduction. If we're not able to reduce a bone with our hands, or if we have a comminuted fracture or lots of different fractures and pieces are chipped off, then it might take an open reduction where we use a surgical intervention. We cut into their tissues, visualize the bone, and put everything back the way it's supposed to be. The next thing we do is a fixation. That means to stabilize and immobilize the bone. So there's external and internal fixations. An internal fixation is back in surgery. When we reduce the bone, we then put in a wire, a plate, a screw. We put in something to hold those bones together. And that would be internally fixating it. We can externally fixate the bone as well by applying a cast or by applying an external fixation device, where we use pins into the tissues to hold an external fixation device in place so they cannot move that extremity. There's a picture of that coming up soon. Then another option a provider has is called traction. There's skin traction and skeletal traction. We're going to talk a lot more about that shortly. But what traction does is pull on the bones to help hold that bone in a state of reduction until we can do surgery and fixate it. So here's some external fixation devices. Remember I said there was internal fixation, where we cut into it, put screws and plates in place, or an external fixation. A cast is an external fixation. A splint is an external fixation. A boot is an external fixation. Boot is a type of splint. And here, on the left-hand side, you see a large external fixation device. This patient has an immobilizer on with skeletal pins in that are holding everything in place, and they cannot move this leg. They can, however, be mobile. They might be able to weight bear on this or partial weight bear on this as they're in the hospital or even at home, and they'll wear it for several weeks just as they would a boot. They'll have to learn self-care of the pins and how to keep it clean and what to do, but this is something they can go home with and maintain their independence and get mobile again. And one of the things we're going to talk about, and we already have talked about, immobility is not good for you. So getting these patients up and moving with a fixation device is the best possible thing we can do for them. All right, so internal fixation, here's just some slides showing you the same thing. Trying not to touch my face, but my nose itches because it's allergy season. So I'm trying to be a good social distancing, non-face touching person. All right, so with internal fixation, you can see in these pictures that there's braces, rods, pins, and plates in place that are holding those bones in place. They are left in surgery, and the bone will heal around those plates. Ultimately, calcification, that plate will be calcified into the bone, or those pins and screws will be calcified into the bone. We don't have to take them out. They're left in place. So there's a neurovascular assessment. I think we spoke about that earlier in the slide. But when there's a traumatic injury, the blood vessels are disrupted, pressure is put on nerves. Sometimes the nerves themselves are traumatically damaged, and the patient then has to be assessed to know if the injury is worsening and if there's a potential emergent situation coming. And we need to know exactly what's going on, because perfusion and neurologic innervation are crucially important to keep that extremity functioning. And so we're going to do our neurovascular assessment. Initially, it's done pretty frequently. You'll find the nurses doing it every 15 or 30 minutes. But after, we're going to do it every hour for the first 4 hours. And then if they're inpatient, every 2 hours for 8. And then every 2 to 4 hours, depending on your hospital's protocol. A lot of patients with fractures, if they don't have fractures all over their body after a car accident or other major traumatic event, they're discharged. So we'll just teach them what to look for at home and what to call and report if they experience it. But this neurovascular assessment is really important for you to know. I think that's clear now. This neurovascular assessment is very important for you to know. The slide even says you must remember this. So we're assessing for pain. These are all P's to help trigger your memory. Pain, pallor. Pain's coming from the release of the cytokines at the tissue from the inflammation. It's also caused from damage to the nerves if we broke a bone. Pallor is a sign of poor perfusion, poor arterial perfusion, and the arteries are what bring fresh oxygen to the tissues to keep the tissues alive. So pallor is a bad sign compared to the same extremity on the other side. So if I broke my leg, I'm going to compare one foot distal to the injury to the other foot. And then paresthesia, that is the shooting, tingling, numbness sensations, shooting pain, tingling, and numbness that a patient would have with neurologic injury. Diabetics get paresthesias if they have neurologic injury from their elevated glucoses. We've talked about paresthesias and we talked about multiple sclerosis. We're going to talk more about paresthesias when we do head injuries and things like that. but paresthesias are a neurologic sign that something is amiss because you're not supposed to have numbness, tingling, and shooting pains in your extremities. Pulses, always you check pulses distal to the injury. That means further away from the injury. So if I break my tibia, I'm checking my pedal pulses. If I break my femur, I'm going to check dorsalis pedis, posterior tibial, and popliteal pulses regularly on that patient to make sure perfusion is continuing. And then I will compare it to the other side. If they have weak pulses in both sides, then that's a central perfusion problem. The brain is not getting perfusion, not the brain, the heart is not getting perfusion around the body. But if one leg is perfused and the other is not, where the injury is, then it's something going on at the site of injury that's blocking perfusion. So pulses, poikilothermia technically means that your body takes on the temperature of the room, the environment. You think of snakes and other reptiles that have to bask in the sun because their body takes on the temperature of the environment they're in. That's called poikilothermia. This word is here to trigger you to think about the temperature of the extremity. Because if I touch one foot and it's cool to touch, and I touch the other one and it's warm to touch, then one foot is getting perfusion and one foot is not. So we're going to be looking at poikilothermia, or the temperature of that foot. And I got to tell you a funny nursing teacher story. One time, a long time ago, I asked one of my students to check the temperature in the foot, and what I'm talking about is just putting your hands on the feet as if they're warm or cold. What she did is she went and she got the thermometer and she actually took the temperature between the big toe and the second toe. So she technically checked the temperature on the foot, but then she and I had a discussion about the proper way to assess temperatures and skin. Thermometers are only for oral, axillary, the infrared across the head, rectal, thermometer probes, or core temperature. We don't check digital thermometer temperatures of feet and hands. Okay, so that's my funny story about poikilothermia. And then the other thing we're going to talk about is paralysis, which is the patient's inability to move. So if the perfusion is bad enough that it injures the perfusion, the swelling, the pressure, the trauma is bad enough that it's severed nerves and significantly damaged muscles and neuromuscular innervation, then the patient may not be able to move it at all. So back to the broken leg example. Can you wiggle your toes? Can you move your ankle? Unless it's a broken ankle. Don't ask them to move it if it's a broken ankle. But if they have a broken tibia, can you move your ankle? Can you wiggle your toes? And can you do it on both sides? Is it bilateral and equal between the sides? So we talked about traction earlier. I'm going to come back to it because we used to use traction all the time in healthcare. When I was a new grad, there were whole floors of nothing but traction patients. Now it's used much less often. It is still on your NCLEX test plan, so you have to know it. And it is still used for some patients. Our surgical intervention has gotten so much better that we no longer use this as often, because when somebody's in traction, they are immobilized for a longer period of time. But if you have an elderly woman who breaks, or man, that breaks their hip, and I said woman because most often osteoporosis in elderly women after menopause, those are high-risk hip fracture patients, right? So if you have a person with a broken hip and they're not a surgical candidate because they have underlying cardiovascular respiratory illnesses and we can't use anesthesia on them, even spinal anesthesia is a risk, then we might place them in skin traction while that foot heals. If you had a massive car accident and a patient has a broken femur or a broken tibia, or they have other problems, and we have to get their emergent stuff related to stopping bleeding and all that, we have to get that done first before they can have surgery on the other things, we might put them in traction, skeletal or skin, to hold the fort and keep them in reduction and alignment until we can get them to surgery. If somebody's only treated with traction, you're looking at 6 weeks in traction like you would 6 weeks in a cast, and that's a long time to be immobilized in bed. So we just don't use it as often as we used to. We now try to get them immobilized in casts or braces, or have some kind of surgical intervention if we can. But the purpose of traction, because you do have to know it, is to decrease the pain and the spasm, because what we're doing is we're pulling the bone back into alignment and we're keeping it there. So that reduces the pain, because a lot of the pain from a fracture is from muscle spasm. It realigns the bone, it immobilizes that extremity and allows the patient to rest that extremity. They're unable to use it while they're in traction. So they're resting, and because it's pulled it back into alignment, we're treating any deformity that might have occurred. We are putting everything in alignment, and we're preventing contractures. And again, most commonly it's used temporarily just to stabilize them until we can get them to surgery. So there's different kinds of traction. I mentioned there's skin traction and skeletal traction. In today's world, skin traction is used more commonly than skeletal traction is, although both are still out there. Again, this with skin traction, our force is applied to a bandage or a boot that's wrapped around their foot, and then we use traction, the use of weights, ropes, and pulleys to apply force on an extremity to align it. So now we have a boot or a wrap that's attached to ropes, pulleys, and weights that are going to align that leg. The most common skin traction we use is a Bucks traction boot. It's in the upper right corner. It's a color picture. It shows a blue egg crate-like thing wrapped with a boot that's attached to somebody's leg and ankle. That is a Bucks boot, and it's most commonly used for a patient with a hip fracture. Once that is aligned and the healthcare provider has placed that as he wants it placed and prescribed the appropriate amount of weight, then that's going to stay on that patient. Traction should always be maintained. The only reason to take it off is if you have a physician's order for it and they say it's okay to remove it, and you think that something's going on with the tissues underneath and you need to check something. But other than that, we're going to leave on skin traction. The other types of traction that are skin tractions that are required here are, we have a halter traction. If you look in the top right, it's a black and white picture. It's also called cervical traction, and we're talking about cervical meaning the cervix of the neck. A lot of patients with compression in their C-spine and neck pain, the healthcare provider will order a cervical or a halter traction for like on 20 minutes, off an hour, on 20 minutes, off 2 hours, whatever. It's not an unusual thing. Some patients go into offices and are treated outpatient with a couple of hours of some kind of traction. There's all different ways to use this, but a halter or cervical traction as a pelvic traction also, which is the next one down. It's a color picture, and you can see, put my mouse on, I don't know if you can see that or not, but you can see these long things coming off their hips, going up to the ropes, which are then suspended. The ropes goes through a pulley and there's a weight suspended. This is for lumbar back pain or to pull. I don't know if you've ever hurt your back. If you lay with your lumbar back, your knees up or your hips tilted up and your back compressed back towards the floor, that relieves a large amount of the pain and the curvature of the spine. And so patients with disc problems and spine problems often have their pain relieved through pelvic traction. And again, on for an hour, off for 2 hours, on for 20 minutes, off for whatever. So the healthcare provider will write an order for time in and time out of that traction. The patient doesn't have a broken bone. They have a strain or an injury, and they are just required to go in and out of traction. Then you start seeing Dunlop's and Bryant's traction and Russell's traction. Those are all on legs, or Dunlop's is an arm, but Russell's is on the leg. And we're going to talk about a skeletal Russell's traction too. You can see with this Russell's skin traction, the upper leg, the femoral hamstring area, is suspended like a little hammock with a pulley. And then the boot, so that's pulling up from the femoral side. And then there's skin traction pulling laterally out. So it's pulling out and up to align that femur. Okay, and that's your Russell's traction. You don't have to have all of these memorized. A Bucks boot is absolutely important that you understand what a Bucks boot is. That was the first one I talked about. These others are more so that you can say, oh, I've heard of that, I've seen it. It's not new to you. As a nurse, and somebody talks about something, you shouldn't be like, oh, I've never heard of that before. It's completely new. But this way you'll be familiar with it. You'll know it's skin traction. You'll know the principles. And then in your specialty areas, you will learn more about management of it. The very bottom one is Bryant's traction. This is a child. It's generally a child in the first year or two of life, and they're laying in bed. Their hips are slightly up off the mattress, and their legs are extended at a 90-degree angle straight up. A child with congenital hip dysplasia can be placed in this kind of traction until we can treat them surgically or with immobilization with the spica cast, which we'll be talking about shortly. But that's a type of traction for a femoral injury or a hip injury in a child. All right, then skeletal traction is when we actually place the weights, pulleys, and wires are putting a pulling force directly on the bone because we have a pin going from the external world through the skin and into the bone itself. And then we hook the weights and pulleys and ropes up to those pins, and it produces the pulling force to keep the fracture reduced in alignment and decrease the muscle spasm. Traction applied correctly dramatically decreases patients' pain. So it's really good for you. The most common skeletal traction that we see inpatient is for a femoral fracture. And what we see is the one in the top right in a color photo. This is the traditional traction bed picture we see for patients. This patient has a Thomas ring with a Pearson attachment. That's what they call it. It's balanced suspension traction. Suspension, this patient in the top right picture here, it's a color picture. The patient's right femur is suspended. You've got your Thomas splint is holding up the femur at a pulling force at an oblique angle and a diagonal upright. Then you have an attachment, a Pearson attachment that's like a hammock for their calf. So the leg is held up off the mattress and hammocked in a hammock. There's skeletal pins in on the femur, and you can see where there's ropes running from the femur up to a pulley at the end of the bed at an angle, and then hanging down with a sandbag weight on it. So that is the oblique upward pull on the femur. And that's providing a pulling force to align that femur in the position it's supposed to be aligned in. And then you can see there's also counter traction here. You see the ropes that are attached at the top of that splint that go backwards to a pulley and hang off the top of the bed. So there's a pulling force the opposite direction so the patient doesn't slide around in bed. That counter traction helps keep the forces aligned and helps provide pulling force in both directions. So this is a Thomas ring with a Pearson attachment in balanced suspension traction. It sounds so technical, doesn't it? The nurse is actually responsible for setting up the bars and the pulleys and the weights. The health care provider usually comes in and aligns it first. They'll prescribe how much weight goes on it. But then after that, the nurses are responsible for the maintenance of this traction. We'll talk about that in a minute. If you look in the bottom left picture, this is a 90-90 traction. The patient has pins in, and their hip is up at a 90 degrees, and then their calf is bent at a 90 degrees. And you can see ropes and pulleys holding weight. So the ropes are going straight up to pulleys that are then pulled to the end of the bed and hung with weights at the end of the bed. So 2 sets of pulleys. 90-90 traction makes perfectly sense. Hip at 90 degrees, knee at 90 degrees. The Gardner Wells or Crutchfield tongs are the bottom middle picture in this slide. And it's used for cervical traction when the patient has a spinal cord injury. We'll be talking more about that when we get to spinal cord injuries in a minute in a next lecture or two. Anyway, so that Gardner Wells or Crutchfield tongs, there's a skeletal pin into the skull of the head. It's meant to immobilize the head and neck so the patient can't turn from side to side and make the injury worse. Usually used temporarily until we can get them to surgery. And we can stabilize it with a rod or a pin or something to keep that bone in alignment and not further damage the spinal column. Then halo traction is also used for cervical injuries if you have fractured bones in your neck, but we haven't severed a spinal cord, a patient will go into some halo traction, and they can if they have an external device like this, they can actually go home with this traction in it. It just keeps them from moving their neck while those bones in the vertebral column heal. There's no spinal cord injury with this kind of apparatus where they're going home on it, but a patient could have halo traction in the hospital and might have a spinal cord injury. All right, here's another picture, the balance suspension traction. So you can see the pulling forces obliquely up to the left and then hanging off the bed. So you have a pulling oblique upward force. You have a forward pull on the calf that are running off of pulleys off the bed. And then you have your counter traction going up off to the right and off the head of the bed. So you have pull in two directions. You can see the leg is suspended. See, the leg is suspended, and the patient has what we call a trapeze bar suspended over their bed. Trapeze bars are almost always present on hospitalized patients in skin or skeletal traction that are immobilized. Any patient that has movement disorders that's going to be in bed rest for a while can benefit from a traction bar. They can be used to help exercise, to help the patient sit up in bed, to allow us access to their back for bathing, skin care, or even bed making. So if you have this patient obviously can't get up and move. They also can't turn side to side. So how do you make the bed on this patient that's in this picture? Well, a traction bed is made uniquely from all, you guys learned occupied and unoccupied bed making in lab in level 1. But a traction bed, not a fracture bed, it's a traction bed, is made from head to toe. So you lay out your sheet and your draw sheet, and if you have any kind of other padding in there, you lay them out as they're supposed to be laid out, and then you roll it horizontal. Like, normally we roll our sheets vertically, so they're on a long axis. This way we're gonna have them on the shorter axis, rolled up, and we'll have the patient pull up on the trapeze bar, so their head and neck and their shoulders are off the bed. We'll undo the old sheets, we'll tuck the new sheets under, and we'll unroll them underneath them. Then they lay back down, and then they'll reach back up to the trapeze bar and pull their hips up for us, and we'll unroll the old sheets and roll down the new sheets from top to bottom. And then once we're past the hips, then they can bend their leg that is not injured and put pressure against the mattress and lift up their femur and their knee, and we can unroll it that far. And the other leg is suspended above the mattress anyway, and then they can just lift up their other leg and we pull it all the way and tuck it into the bottom, and we make the bed from top to bottom. So we can still get clean linens on them. Doesn't have to be done every day, but it should be done periodically. Wrinkles and soiling and damp in linens certainly are going to impair their skin. If they're going to be in traction for 6 weeks, we need frequent dressing, frequent bed changes, clean linens, and we need good hygiene. If they have bathroom needs, they're likely to get soiling and dampness. If they're sweating, because sometimes just being in bed, they get overheated and things. So you just want to make sure that you've taken good care of your patient, you're taking good care of their skin. You're going to be assessing their back and their hips and their ears and the back of their head because they're on bed rest. We're looking for skin breakdown. That's all part of that great nursing care that we do on every patient that's immobilized. So nursing care of a patient in traction. If they have skeletal traction, those pins are going from the external environment into the bone. And so those pins have to be cared for. The first few days or even a week, they're going to be oozing. They might have blood coming out in this area around it. We want to keep the pin clean. We don't want debris and gunk to build up on the pin itself. If you have a clot at the site where the pin is inserted into the skin, you're not going to dislodge that clot. We don't want to get the bleeding started again. But if you have blood that's leaked up and it's coming down their leg or up on the pin, you want to clean that area. You're going to do this with sterile technique. Sterile saline is all that's required, with sterile gauze, sterile gloves, sterile field. So you pour your water before you put on your sterile water before you put on your sterile gloves. And then you glove and you have got your sterile 4x4s or whatever and dip them and you clean and you do your pin care. That's going to be done. Most hospitals will have you do that every 4 to 8 hours when it's a new pin. After the pin's been around a while, you only have to do it daily. If they're going home with one of those external fixation devices, the patient doesn't have to do pin care every 2 to 4 hours. They're just going to do it once a day. So, but pin care has to be done, and it's to keep that pin clean and keep the site sterile. And this gives us a chance to do a good inspection of that site, make sure there's no redness and swelling and signs of infection at the site. Because we'll have to call the healthcare provider if there is. Then every couple of hours, 2 to 4 hours, we have to go in and we have to make sure the ropes are smooth, not rubbing the end of the bed. They're running through the pulleys freely. The weights are hanging freely, not touching the bed, not touching the floor. They don't have, because if they hit the floor, then the weight is released and there's no longer a pulling force. The patient's going to hurt and their bone will come out of alignment. So we want to keep the patient pulled up in bed. Don't take the traction off to pull them up in bed. Just pull them up in bed like we always do with the draw sheet. It will be fine. They always have 5 pounds of pressure or 10 pounds of pressure pulling on that leg. Every couple hours, we want to check the knots and make sure they're secure. That's part of the nurse's role, and you want to document it every 2 to 4 hours, that the knots are intact, the rope is running freely through the pulleys, that's not running, touching the bed, all of that needs to be documented. So we also want to make sure if the patient has counter traction, that counter traction is in place. Sometimes the healthcare provider will enhance counter traction by the angle of the bed that if they want the patient flat in bed, there's higher counter traction with a backwards pull. If the patient's sitting up, that's a little less counter traction. So the doctor feels like counter traction needs to be increased. He'll ask you to lower the patient's head, and it'll increase the counter traction. The patient's own body weight is going to provide that counter traction. Position and alignment, you want to make sure knees are pointed up, toes are pointed up, the body is, whatever broke extremity it is in proper body alignment so they don't get contractures or joints tightening up in the wrong position. The patient's going to require skin care of any area that's touching the bed. So think a patient laying flat in the back on bed, it's going to be the back of the head, the ears, the head, the neck, right there where the cervical and thoracic spine come together. At the hips, at the sacrum, all the way down, the heels, the ears, all places that can become potential pressure sites that have to be assessed and inspected daily. We're going to keep their skin dry, not like cracking dry, but I mean not moist from incontinence or stool or sweat. So we want their skin to be dry. We also want their linens to be dry. That's just all part of good care. Elimination, this patient's going to be on bed rest, so constipation is going to be an issue, and they're still going to have to go to the bathroom and have bowel movements and urination. So what we don't want to necessarily catheterize that person. We know that coddies are a huge problem. So we don't want to use a big fracture pan either, because fracture pans are really tall. They're about 4 inches tall and they're pretty bulky. So if you're laying on your back in bed trying to get your buttocks up and you can't come into a sitting up position, a regular bedpan is almost a nightmare for these patients. So we use a fracture pan with a very narrow end, and that just slides up under their buttock. You just want to make sure the opening is over where their meatus is or their sphincter is so that you can catch any debris that they're eliminating. But we use a special bedpan called a fracture pan for that. And then, of course, they're going to have regular good hygiene, neurovascular checks. They still have a broken bone, and they still require neurovascular checks every couple hours. And we've already talked about bed making variations. So again, the complications of traction are not unlike the complications of a fracture and immobility. So what we're looking at is a lot of the same issues. Neurovascular compromise, we still are worried about perfusion and neurologic innervation to the extremity that was damaged. Pain is often the first symptom patients experience with ischemic injury. So if their perfusion is stopping or slowing up, the patient might complain of ischemic pain, burning pain in that extremity. Infection is an issue. Skeletal traction, because there's pins directly in the bone, always increase the patient's risk for osteomyelitis. We do good pin care and with sterile technique. Skin breakdown is an issue because this patient is immobilized for an extensive period of time. So we're going to do things like shifting a little bit from hip to hip, having them use that trapeze bar to sit up, having them move every couple hours. They may not be able to turn. We can move and shift every hour. Sensory deprivation, and we're going to keep their nutrition up and their hydration up, because we all know poor nutrition, poor hydration, and we're not going to, when we pull them up in bed, we're not going to drag them. We're going to lift them and pull them up so there's no more shearing force on their skin, because we know those things all increase the risk of skin breakdown. And then these patients are immobilized, in bed, unable to move. Sensory deprivation is a problem for all fracture patients. So we're going to see, you want to make sure the TV is where they can see it. They have the controllers nearby. You want to make sure they have other alternative things that are going to entertain them. You can have family members video stuff and send it to them if they can't come see them. You can give kids, and if they're interested in gaming, Game Boys and things like that, like, I don't know, they're 2 DSLs now or whatever the little handheld devices are, anything like that, they can still do those in bed. Magazines can be read. Books on tape are helpful for some patients. So also sensory improvements. You also want to make sure they know what day it is. They have a clock where they can see it, that we keep them oriented to reality. On the boards in the room, we always put what day it is. We always put who the nurses are. We want to make sure a clock is where the patient can see it. That's all part of good nursing care to keep your patient's mind intact. And then any other complication of immobility, we're going to keep our eyes out for, and those are in part 1 of this lecture series. So kidney stones and pneumonia and things like that. Get those patients deep breathing. All right, casts is another method of immobilization, of fixation. Casts are always external. We can't do an internal cast. That's kind of weird. Casts, the only internal cast there are is in your urine. When casts are also those fibrous strands of mucus that come out in your urine. Those are also called casts. But a cast in the mobility lecture is an external device. It's plaster of Paris or fiberglass. A synthetic cast is a fiberglass or a similar substance. Plaster casts take up to 24 hours to dry. We don't use them as often as we used to. There are still a few circumstances that they're used, but for the most part, plaster casts are only used very rarely. Gosh, I haven't seen one in a long time, but they're still out there and you need to know the care of them, because plaster casts take 24 hours to dry. And plaster of Paris, what do you know about plaster of Paris? Where it smells musty and chalky until it's dry. So there's an odor to it until it's dry. It also is, until it's dry, it can be manipulated and changed. So you only want it, once the patient has the cast applied, you only want to touch that patient's cast with the palms of your hands or the flat surfaces of your fingers. You never want to poke on it, because you can put an indent in it and make a pressure area inside the cast that could break down their skin inside the cast. Also with a plaster cast, you want to make sure that patient is turned every couple hours so that all the casts can be exposed to air and it can all dry all the way around it. You don't want the patient to have their leg in a pillow the entire time and only the top part dries and the bottom part is still musty and wet and doesn't dry well. So that's for a plaster cast. Fiberglass casts dry within 15 to 20 minutes. So usually the patient can be up and moving pretty quickly after the application of a synthetic cast. For all casts, we're going to put a stockinette, which is like a knit covering over the extremity that we're casting. And then we're also going to put cotton or synthetic batting over that stockinette. And that's going to be padding under the cast, so the hard surface of the cast isn't directly pushing on the skin. And then the provider will apply that cast from distal to proximal, usually. But however he does it, that he thinks is best for reduction and fixation of that extremity, because he'll have manually reduced the extremity and he'll be applying a cast to fixate it in that position. So the stockinette will be applied, and then you'll have some padding. And then after he gets most of the cast on, he'll pull the edge of the stocking, he or she will pull the edge of the stockinette up, roll it over the top of the cast, and put a layer of casting holding the stockinette that way. And that gives you a soft surface at the top of the cast and the bottom of the cast, so that it's not sharp edges from the synthetic cast. That's a form of petaling the cast. If the provider does not do that and you have sharp edges of the cast against the patient's skin, you can use adhesive tape, and you cut small pieces and you set it inside, sticky side towards the cast, smooth side on the out, and you wrap it over the sharp edge like the petals of a flower, cushioning that sharp edge from the patient's skin. It's called petaling the cast. Let's see. After the cast is on, now remember this is a traumatic injury. The cast is generally going on fairly soon after injury. Sometimes the doctors will delay it 24 or 48 hours and just have you manually immobilize it with an air splint, but most of the time they're placed pretty early. And so we want the patient to keep that extremity elevated quite often to prevent future swelling. We also want them often to use ice packs on the cast because ice does not reduce current swelling, but slows perfusion to prevent future swelling. So elevation and ice are used after the cast is applied. And now we have a circumferential dressing on that extremity, and it's a potentially swelling extremity. So neurovascular checks really frequently are very important. You want your patient to report paresthesias, pain, paralysis, and change in color or temperature to that extremity as soon as they can. So again, neurovascular checks are taught to your patient, and as nurses, we will be doing them. All right, casts also can have pressure areas under the cast, so be aware of that and make sure that cast padding is in place. We want to teach the patients, do not pull the padding out because it's there to help prevent pressure injuries. So there's lots of care of a cast. There's certain things we just have to know. Casts should not get wet after they are applied. So if it's raining outside and the patient has to go out, they need to cover their cast with plastic and tape that plastic around it. If they're going to take a bath, which is very important, we still want our patients to bathe, they can cover that cast with plastic. They cannot submerge it in the bath, but they can keep it elevated on the edge of the tub while the rest of their body is in the tub, and it's covered with plastic to prevent it from splashing and dribbling and things like that. We'll tape it on the top and the bottom to seal off the edges so no water can get under that plastic covering. A trash bag will work with adhesive tape or plastic tape. So we want to keep the cast away from moisture, and anytime they are going to be around moisture, cover it with plastic. We actually are going to put our hands on the cast when we see our patient. If our patient's in the hospital for surgery, abdominal surgery after a car accident, but they had a broken arm in the same accident, and we're assessing that patient every couple hours, we're going to touch that cast, or we're going to feel for hot spots. Hot spots and pressure points can be signs of infection or injury to the skin under the cast. You'll actually feel a warm area if the patient's developing osteomyelitis. Osteomyelitis, heat, pain, redness, and swelling under the cast. That heat will transfer through the cast to our palpation abilities. So it's something to keep in mind. We want to teach the patient, and same for us, put nothing under the cast. It's going to get itchy under there. Over the course of the weeks that the cast is on, your skin is constantly sloughing and growing new epidermis, so you're going to get old, yucky, sloughed skin building up under there, and it's going to get itchy. So their temptation is going to be there to stick a pencil under there and scratch, or a fork under there and scratch. So it's important we teach them nothing goes under the skin. If they need to itch under the cast, what they recommend is getting a blow dryer on the cool setting and just blowing cool air down in the cast, either from the bottom or the top of the cast, whichever is closest to the itchy area. And that can help decrease the itch. Interestingly enough, sometimes if you push on the same area on the opposite leg, that can help reduce the itch on the leg that has the injury too. Just something that helps sometimes. So blow dryer on cool, nothing under the cast. You have to really watch children who have casts, because a cast is now like carrying an extra pocket around them. It's a great place to store Hot Wheels or lima beans that they didn't want to eat at dinner and hide it from mom or dad. Down in the cast it goes. But now we've got food products or toy products putting pressure or potentially breaking down under the cast. Not a good picture. So teach them nothing goes under the cast. Nothing goes into the cast. It is not a pocket. And they should not pull the padding out. Padding is important in your cast. Is the client allowed to weight bear or not? That is a provider's order. The client will be told if he needs to walk on crutches and never put weight on that extremity, or if they are allowed to partial weight bear or toe touch weight bear, or if indeed they're allowed, now that we've got a good strong cast on it, if they're allowed to weight bear. A lot of times they'll do non-weight bearing on it for a couple weeks, and the doctor will gradually put them in toe touch weight bearing or weight bearing. And at some point they may move them to a walking cast that actually allows weight bearing. If the patient's going to be using crutches, and that would be for a leg injury, if you have an arm cast, you don't need crutches. But if you have a leg injury and you have crutches, then we'll teach them a 2, 3, or 4-point technique, depending on the kind of weight bearing the doctor's allowed. Non-weight bearing, then they've got to do 2-point crutch technique. If they're allowed to weight bear, a 4-point or a 3-point will be fine. If you don't remember your weight bearing and your crutch walking techniques, which I'm a betting woman and I would bet we don't all remember, I will be posting a YouTube video under your learning activities section to refresh that in your mind. The NCLEX blueprint actually specifically mentions teaching crutch walking to patients in the blueprint as something that technically could be tested on your NCLEX exam. So I want you to refresh your mind on that before you get to NCLEX at the end of the summer. So I'll be posting a video for you to watch during LA time. Okay, one other thing, I want to go back to the previous picture, 2 pictures ago, where we were looking at casts. You can see there's short leg casts or long leg casts. We have arm casts, short arm casts, or long arm casts. And then you see the cast, one of them is a total body cast with a bar between the 2 legs. Any cast that it's casted all or part way down, both legs with a bar in between it is called a spica, S-P-I-C-A, spica cast. Most commonly used for hip injuries and pelvic injuries. Kids with a congenital hip dysplasia may be in a spica cast for a year or more. With patients have full body, like these body casts with bars in between the legs, bowel and bladder issues can be a problem because we're going to cut openings out through the perineal area for them to eliminate with, but staining and all that, you want to teach them to pad and cover those areas when they want to eliminate so it doesn't cause the stool to stain or get up under that cast at all. And one thing that's really important, never, ever, ever turn your patient or support your patient by the bar in between the legs of the cast. That bar is just a thin little thing of plaster of Paris or fiberglass. And if you pull on it or try and support your patient with it, it can break and become dislodged. There's all kinds of stories about nurses trying to turn their patient by grabbing the spica bar and turning and moving the patient as a unit. Absolutely bad technique, bad nursing care. Never, ever, ever do it. Sounds funny to somebody would think of it, but don't. Okay. So anytime a patient has a fracture, there are some complications we worry about. Infection, osteomyelitis, one of the big ones. Osteomyelitis, we talked about it with open fractures and with skeletal pins being a risk. If a patient actually gets bone infection in their bone, it is an 6 to 8 week course of antibiotics. They can start with IV antibiotics. If they're inpatient, of course, IV is pretty easy. If they're home, then we can do home nursing to manage their IVs through a lock, and they can get IV antibiotics from home care nurses. They'll get IV antibiotics for a few weeks, and then they'll be switched to oral, but they'll be on antibiotics for 6 to 8 weeks. That means there's probable side effects associated with that we'll be aware of. But that's the treatment for osteomyelitis is antibiotics for 8 weeks and immobilization. We will immobilize that extremity. So this kid who was walking around with a walking cast and then they get a bone infection may now be in a wheelchair for 8 weeks instead of walking around. And so there can be some psychosocial things that go along with a longer term immobilization than we were originally expecting. Compartment syndrome is another complication that we'll be talking about in a minute on a different slide. So I'm going to wait on that one. Nerve injury, anytime you've got a traumatic injury, it could damage the nerves. Peripheral nerves have a neurolemma over it that does regenerate, whereas central nerves, the myelin doesn't regenerate well, but neurolemma can regenerate. So nerve injury can get better over time if there's been some in an extremity, but we don't want it. A fat embolism, there's also another slide on that coming up. We'll talk more about it. Cast syndrome comes from body casts, and it can affect your respiratory and bowel elimination cycle from being in a long-term immobilization of the abdominal and thoracic area. Volkmann's contractures, I have a picture of that coming up soon. A contracture of the wrist and the fingers, and a contracture then, that's when your tendons and ligaments are actually shortened and frozen, so that extremity becomes unusable. And you don't want wrists and fingers to become less functional. So we want to prevent that. Delayed union or malunion is when the ends of the bone don't join back together, or they join back together in the wrong way. So it's no longer in proper alignment. So if it takes longer to heal and we don't get a good heal in 6 weeks, the patient ends up in a cast or contraction or immobilization device for 12 weeks or 16 weeks from delayed union. That's a problem. That could be from perfusion, nutrition, overall body health, comorbidities like diabetes. Lots of things can lead to that. Okay, avascular necrosis is when our traumatic injury is decreased perfusion. And when you decrease perfusion, it causes necrotic tissue. Necrotic tissue does not regrow. It is dead tissue. So we don't want perfusion to cease to the point that dead tissue is in the bone or the surrounding tissues. We don't want necrosis, but that is a complication that can occur. If somebody has an injury at a bone or a joint, arthritis is pretty common afterwards. Osteoarthritis, not rheumatoid. Osteoarthritis is pretty common afterwards. So these kids have, oh, I broke my ankle 3 times, or I broke my bones repetitively. Quite often those kids later in life have the wear and tear osteoarthritis of that joint. And then some patients have a syndrome of pain that just doesn't get better after nerve damage. And so we have them in long-term care in a pain clinic managing their pain. Okay, so I mentioned there would be a couple of complications that had later slides. A fat embolism was one of them. The long bones of the femur and the pelvic bones in the hip and pelvic area have a fatty bone marrow in them. So when that patient experiences a fracture of that area, that can release yellow fatty marrow into the circulatory system, because now we've got openings in the blood vessels right there where the blood vessels were traumatized, can be released into perfusion, and that fat embolism can go through the vena cava, which is returning to the heart, through the right side of the heart to the pulmonary arteries, and then out to the capillary beds in the pulmonary arteries, and that fat embolus will lodge and block perfusion through the pulmonary bed. So an area of the alveoli is not able to exchange gases when the venous blood is coming to it, and we're trying to get oxygenation in so it can become arterial blood going around the body. So we're actually going to block an area of the alveoli and the gas exchange, and that will cause increased pressures in the lungs, pulmonary edema, causing frothy sputum, where other places in the lungs are also having difficulty exchanging gases because they have fluid now over that basement membrane, and oxygen's having a hard time getting through it. They've got frothy and liquid secretions, crackles in their lungs, fluid in their lungs. That makes the heart rate increase, and the heart has to work harder against these pressures to perfuse. It may actually cause a backflow of pressure that causes leakage of blood into the lungs. You get pink tinged sputum, so that's commonly seen. And actually the lack of surfactant the surfactant in the alveoli can be destroyed if there's fluid that builds up in there, will actually cause atelectasis in the alveoli to collapse on themselves and not be open and not engage in gas exchange because it's difficult to pop those airways open, those little alveoli open through deep breathing. The surfactant helps keep it open, but once they're collapsed, it's really hard to get a strong enough breath to reopen them. So you can see that having a fat embolism could impair your life. So what symptoms will we see our patients have? Shortness of breath, difficulty breathing, really labored breathing. They may experience respiratory failure where their CO2 levels are climbing and they cannot get their O2 levels back into a therapeutic range on a blood gas. You might see hypoxemia if it's bad enough, not just hypoxia a little bit of tissue hypoxia, but hypoxemia where systemically there's not enough oxygen in the bloodstream. Their level of consciousness may decrease. You might get pinpoint petechiae on the upper body, on their trunk, on their neck, and in their mucous membranes of their mouth, on the inside of their cheeks. They might have pinpoint petechiae. Something to be watching for. That's pretty rare. I've seen a couple of fat embolisms and pulmonary embolisms, and the petechiae are not your most common symptom. Your dyspnea, tachypnea, and hypoxia are your most common symptoms. So what do? We'll put some O's on them. It might be a nasal cannula or a mask, but most commonly you might see the patient end up in a non-rebreather mask where we can deliver high concentrations of oxygen to them. Non-rebreather masks can deliver up to 100% oxygen if we need to. Dobutamine is a pressure stabilizing drug that will bring up your blood pressure, but it also eases the workload of the heart. And remember, a pulmonary emboli, up in the pathology part of this slide, we talked about how the work of the heart increases, setting them up for heart failure. So the dobutamine can help stay that off. If they need respiratory support in terms of a ventilator, BiPAP, CPAP, we can do that. How do we prevent fat embolism? Well, fat embolism is when marrow, yellow fatty marrow, breaks off and gets in the bloodstream. So moving that fractured area a lot, handling that patient is more likely to cause it. So immobilize the fracture earlier. Try not to move that fractured area any more than absolutely possible. And glucocorticoids intravenously can be prophylactic for a fat embolism. So the steroids, IV steroids. Compartment syndrome. This is a separate exemplar, and as such, you know there will be questions on this particular condit all by itself. This is a very dangerous sequela to any time we have a circumferential dressing on a patient. And there's lots of times that a circumferential dressing or a circumferential constriction of circulation might occur. It could happen in a burn. In this case, we're talking about putting a wrap or a cast or a splint on that is now over an injury that is swelling, and the compartments can't expand because we have an immobilized fixation device around it that decreases the ability of the tissues to expand. So when they can no longer expand, the pressures push inward and they put pressure on the blood vessels, arteries, and veins. Venous return will decrease and arterial perfusion will decrease. So now oxygenation has decreased to that extremity and the tissues begin to feel ischemic. Ischemia is going to ultimately, if it's bad enough, ultimately kill those cells. But when they first are experiencing it, the tissues are going, oh, I need blood, bring me blood. So they're going to release histamine. They're going to release bradykinin. They're going to release prostaglandins, all those cytokines. Those cytokines make the basement membrane more permeable, and they make more fluid leak out of your basement membranes, which means it makes the edema worse. The body is trying to get perfusion to the side. It's saying, bring us blood. But when it does that, the basement membrane leaks more and the edema gets worse, and that puts more pressure on it, which causes more ischemia. And so the tissues then release more histamine, bradykinin, and prostaglandin, which causes more capillary leakage, which causes more edema. So it becomes a cycle that's unending unless we do something to break the cycle. So if we don't do something, it can cause a complete death and loss of nerve function in that extremity. It can cause complete perfusion loss to that extremity and cause ischemia of the tissues and ultimately a need for amputation. It can cause infection from poor perfusion, so we aren't cleaning out the debris, and it can set the patient up for osteomyelitis. And also, all that ischemic stuff and the breakdown of cells and the breakdown of red cells, because it's going to kill the cells that are in the area because they're not perfusing, are going to cause myoglobinuria, the breakdown of muscles and blood cells, are going to cause myoglobinuria and rhabdomyolysis as muscles break down, and that puts an extra strain on the kidneys. Then get acute renal failure, acute tubular necrosis, and acute renal failure. So we don't want any of that. Technically, in our arms and legs, there's 38 different compartments that can store fluid. I know I said I'd mention something about fluid and hip fracture. I think I did. The hip capsule can contain 1 liter of fluid. Patients can be third spacing a lot of fluid without us seeing signs of obvious bleeding. And yet that's building up pressure and causing pressure on nerves and blood vessels in that area that we may be unaware of. So what do we see our patient experience? So what findings do we have? Well, remember our neurovascular check: pain, poikilothermia, pulses, pallor, paresthesias. That's what we're looking for. We're doing a comprehensive neurovascular check on this patient. We're going to have extreme pain out of proportion to what they've been experiencing. So if they were having pain 4 out of 5 with this broken bone and it was being cared for with some Tylenol and that was kicking it down to 1, it was manageable. Now all of a sudden they're going, oh my gosh, my pain is 8 and it's getting worse and I don't know what to do. And then we go check it and they have tingling or shooting pains, and they'll have pallor and cool extremities because there's no fresh arterial perfusion. Arterial blood is what makes your leg pink and warm. So the leg is now cool and pale. And we feel for pulses. Pulses are arterial perfusion. So my dorsalis pedis, my posterior tibials are weak or absent compared to the other side. Then now I have signs of potential compartment syndrome. So what do I have to do? Well, I've got to get rid of the external dressing. If they have a cast or a splint on, I need to get the wrap, the splint, or the cast off. So I'm going to notify my provider as soon as possible because I'm now undoing his medical treatment and get an order for this. So we're going to check the pulses with a Doppler, make sure that what we're feeling really is real, that if there's only palpable by only audible with the Doppler, no palpation, we'll report that. Or if they're not even audible with the Doppler, that's an emergent situation. No arterial perfusion, absolutely emergent. Get the wrap off, bivalve the cast. A cast bivalve means we're going to cut the cast on the longitudinal axis. So if what you see here, I'm going to walk you through these pictures on this slide. So there's a woman with a saw. That is not a cast saw. That's the saw you saw down some trees with, or you saw wood with. A cast saw is like the one with the green check. It's got a circular blade. The blade does not spin. It actually vibrates and cuts through the cast with vibration, so it will not cut the skin. If you turn a cast cutter on and hold it against your skin, it will not cut you. So we use a cast cutter to protect the patient's skin. In the bottom left on the pink cast, you see a nurse holding a cast cutter to the cast. It will actually slice the cast in half. We slice it down the longitudinal axis. So the bottom part of the cast now is a splint to maintain the alignment and not allow the patient to move. The top of the cast will be placed loosely on top and taped gently in place. Now the leg has room to expand if edema continues and it's not putting pressure on those vessels. That's called bivalving a cast. The other time we use a cast cutter on a cast, I'm going to go back for just a second. So when we talked about cast care, it said bivalving in window. So bivalving is cutting the cast on the longitudinal axis. A window is when we cut a square into the cast. Before the cast goes on, we should have looked at the leg, make sure that there was no bruise, no cuts and sores there. If we get a hot spot or we had a sore into that cast and we want to take a look at it, we can cut a little window out of the cast. Take that plug of the cast out, look at the skin underneath, see what it looks like. If we need to do dressing care in there, whatever we need to do, then put the little plug back in, tape it down, and we've got a window in our cast to work with the skin underneath. The bivalve is a longitudinal cut. On this slide, I jumped over a couple of things. I'm sorry. I mentioned nothing of the cast. I talked about all the dead debris skin. So when this cast comes off 6 weeks later, they're going to have a lot of junk on their skin. They can put moist compresses on it. They can bathe. They can use gentle scrubbing. You don't want to get in there and really scrub till the tissues are raw, but moist compresses and bathing can help get that old dead junk off. And they're going to want it off because it's kind of nasty and stinky. I also didn't talk about exercise, but patients can do isometric exercises under this. We talked about quad setting, glute setting, so they don't atrophy. If you have a cast on your arm, you would get the patient to tighten up the arm, doing isometric exercises to help maintain muscle strength. Because just putting a cast on and not using that extremity is going to atrophy the muscles. It just combats the atrophy. So back to compartment syndrome treatment. So first, get the cast or the splint or the wrap off. That's your first step. So we're going to release the wrap or bivalve the cast. The patient needs hydration, so make sure their IV is running. You have an order from your healthcare provider for fluids. Sometimes docs will leave standing orders for this, so the nurse can automatically bivalve and start an IV and hang some fluids. If the patient does not improve with the removal of the wrap or the cast, it might be necessary to go in and the surgeon will do a fasciotomy. Remember, the fascia is the thick fibrous sheath that goes around the muscles, and it doesn't have as much expansion capability as skin and other soft tissues do. So sometimes we have to go in surgically and cut through the wall of the skin and the subcutaneous tissue and actually put cuts in the fascia to allow room for expansion to restore the perfusion to that extremity. If we don't get this taken care of, we don't identify it early, we don't treat it early, or if we aren't able to resolve it adequately, the patient may have enough ischemia to the extremity they're required to have an amputation of that extremity. It also can lead to Volkmann's contracture. I mentioned that earlier. The farthest right picture at the very bottom is a picture of a patient with a Volkmann's contracture. And you can see the wrist is immobilized and the fingers are unable to move in a non-functional position. So they lose a lot of function in their hands and their wrists. That's not pretty. That would be obviously compartment syndrome of an upper extremity. If you have compartment syndrome of your leg, it won't give you a Volkmann's contracture. If a patient has compartment syndrome, the tendency, we always think, oh, gee, they have an injury and it's painful, let's elevate it. A lot of times elevation is the right thing to do. In this circumstance, it's not. This is caused from decreased arterial perfusion. So we do not want to elevate. That's going to slow arterial perfusion to the extremity. The pallor isn't going to get better if we elevate. So we want to keep their extremity at lateral. We're not necessarily have to hang it down. We can if we want, but we can keep it on the bed at the level of the hips and the abdomen, not elevated above the heart. Absolutely. And often we get all up in arms about a fracture, immobilization, injury, and we think, oh, apply ice, apply ice, apply ice. Well, ice decreases perfusion. And for a lot of injuries, we do elevate and apply ice. For this injury, we do not elevate and apply ice. Okay. So a deep vein thrombosis you studied in level 2, and I don't need to expand a lot about this, but these patients are immobilized. These patients are on long-term immobility. So they immediately hit that Virchow's triad. And so the DVT is thrombus with inflammation of that vein. For most patients, it's in the iliac and femoral veins. It can affect superficial veins, but the most common ones are the iliac veins and the femoral veins. And so most of the time, DVTs are in the leg. And what can happen is the thrombus is loosely adhered platelets causing a clot, and fragments of that clot can break off and embolize and end up causing a pulmonary embolus, which I believe you cover later in this program. I don't think you've covered it yet, but we talked about fat embolus. It's kind of the same thing. So what causes a DVT? Stasis of blood flow, damage to the endothelial of a blood vessel, and blood hypercoagulability. Well, bed rest causes stasis. The traumatic injury caused endothelial damage to a blood vessel. You've already got the first two of Virchow's triad. If they have any one of the third things that causes the blood to become hypercoagulable, then the patient is a prime candidate for a DVT. So who's at risk? Patients who've had surgery, patients who are immobilized. That hits our patients. Patients that are trauma patients. That's also my mobility patients. Pregnant women, obese patients, cancer patients. Cancer patients have that hypercoagulability. Estrogen therapy, hypercoagulability. Or long distance travel, patients that take airplane flights for 15, 16 hours across the world are often, they're high risk for DVT if they don't exercise and keep their legs moving during the flight. So what symptoms do we see in our patient? On the affected leg, you will see swelling, edema, pain with movement, pain, tenderness with palpation. We used to always go in and touch these legs. We're trying not to elicit a Homan sign where we flex the ankle like this. I know that causes shooting pains up the leg, but if we do it over and over and over, it's the same as exercising that leg, and so we're going to cause it to embolize quicker. So if we have done a Homan sign or the patient hyperflexed their foot and ow, they got shooting pain, good enough. I can document it once. I don't need to check it every day, and I don't need every nursing student in the face of the planet to check it on that patient or every medical resident. So we know they have tenderness. If we palpate it, that leg hurts. We try not to handle it more than we have to. Superficial veins may be dilated because blood flow is being routed around this clot. They'll feel like their leg is full and thick and heavy. They'll have warm skin on the affected leg, and the affected leg below the clot will be erythematic. They'll be red and swollen and painful. So we talked about Virchow's triad. This triad shows hypercoagulability, endothelial damage, and venous stasis, and it lists things that cause each of those things. And you can see if our patient has immobility, that's venous stasis. If they have endothelial injury from the trauma itself, and we probably put some IV catheters in there, which certainly could cause it. And if anything happens to cause them to become hypercoagulatable, so if they've got secondary comorbidities, or if they have cancer, or if they've been post-operative from the anesthesia and all of those things can cause hypercoagulability. So if our patient hits that triad, they're super high risk. So treatment is generally preventive, keeping them exercising as much as possible to the extent their injury allows them to, putting them on prophylactic heparin, like love knock shots if we need to. Or if we have to, we can use Coumadin. We start with heparin, but we can use Coumadin if we need to. We also can do things like not over the counter, but oral anticoagulants like Xarelto and things like that, just to decrease the risk of blood clotting. Aspirin, an anticoagulant. That's the end of this section. Thank you. And I will be shortly posting this, and we'll move to the third lecture in a little bit.